MSK, lower extremity nerves. All right, so the lower extremity nerves are kind of a beast on its own, but I'm just going to kind of break down for you what you need to know. First off, we have the iliohypogastric nerve. What they want you to know is that you'll see suprapubic burning following abdominal surgery. All right, so if you ever have suprapubic burning pain, tingling pain following abdominal surgery, it's probably iliohypogastric nerve damage. All right. Next is going to be genitofemoral nerve. The genitofemoral nerve, what they want you to know is that there's an absence in the cremasteric reflex. So if you see an absence in the cremasteric reflex, then you know it's a genitofemoral nerve issue. Next is the lateral femoral cutaneous. Lateral femoral cutaneous is a little bit higher yield compared to the others. It's associated with like obesity and tight clothing as well as pregnancy. And what's going to happen is that the patient is going to have decreased anterolateral thigh sensation. So they're not going to be able to feel like that anterolateral portion of their thigh, the outside portion of their thigh. All right. And it's going to be associated with obesity, tight clothing, and pregnancy. That's known as meralgia paresthetica, which is compression of the lateral femoral cutaneous nerve, once again, from tight clothing, obesity, and pregnancy. Next, you have the obturator nerve. Obturator nerve is going to be a decrease in adduction after usually pelvic surgery or motor vehicle accident. All right, so decrease in adduction after pelvic surgery. Next, you'll also have like an area of the thigh. You'll have decreased thigh sensation that's more medial, okay? Decreased medial thigh sensation. But the decrease in adduction is also important. Next, you have the femoral nerve. The femoral nerve, what you're going to be seeing, and this is very high yield, a couple things. You're going to have a decrease in the patellar reflex and leg extension because the femoral nerve is going to encompass the whole front of the knee, right? So if that whole front of the knee is gone, you're going to have a decrease in patellar reflex. So take a look at the photo of where you will see sensory loss, and then you also have that motor loss in that same region, okay? So you have a decrease in the patellar reflex and leg extension. If you see ever a decrease in the patellar reflex, it's talking about the femoral nerve, okay? Do not get confused, don't get rattled, all right? So another thing that can cause these, so pelvic fracture can cause this, but compression from retroperitoneal hematoma or psoas abscess can cause femoral nerve compression. So if you have retroperitoneal hematoma, if you're bleeding in the retroperitoneal space, and it starts to compress, it can compress the femoral nerve. It can lead to a decrease in patellar reflex. All right, so keep that in mind. But overall, decrease in patellar reflex, retroperitoneal hematoma, or pelvic fracture, or lastly, psoas abscess. Next is the sciatic. So the sciatic nerve, what you need to know is that it can be caused by posterior hip displacement. So sciatic nerve damage and posterior hip dislocations, and those can be caused by either a fall in a frail elderly patient or a motor vehicle collision. So remember, posterior hip dislocation can damage the sciatic nerve. Well, how does a posterior hip dislocation occur? Two things: fall in a frail elderly patient or a motor vehicle collision. Okay, where essentially where the knee hits the dashboard and the hip gets posteriorly dislocated. Okay, and what you'll see on presentation is that the leg will appear shorter and internally rotated compared to the opposite leg or the unaffected leg. All right, so the leg that's affected will appear shorter and internally rotated. So keep that in mind. That's very, very important. The sciatic nerve damage caused by posterior hip dislocation, as well as which can be caused by a fallen frail elderly patient or an MCV, motor vehicle collision, where the knee hits the dashboard and it causes a posterior dislocation of the hip. The leg will appear shorter and internally rotated. Another cause of sciatic nerve injury is piriformis syndrome. Okay, piriformis syndrome is essentially where that piriformis muscle compresses the sciatic nerve where it leaves. Okay, now the sciatic nerve is going to split into the common peroneal nerve and the tibial nerve. The common peroneal nerve, in my opinion, I just call it the fibular nerve, but you have to know that it's also known as common peroneal nerve. All right, so this is what the sciatic nerve is going to split into: the common peroneal or fibular, as well as the tibular or tibial. So let's start off with the common peroneal or fibular. What they want you to know is kind of a plethora of things. They want you to know sensation as well as motor. So there's two things that you're going to be kind of, knocked out. The first thing that you should take into effect is the superficial fibular nerve or superficial peroneal nerve if it gets knocked out, it's going to cause a sensory loss between the big digit toe and the second digit toe. Okay. And that's the flip-flop sensory loss pattern, right? Where you put your feet in flip-flops, it's between your big toe and your second toe. That's where the sensory loss occurs for superficial peroneal nerve. Okay. That's kind of the only thing that you really need to know. Everything else is going to be affecting just like the common fibular peroneal nerve. That's what I care about. And what you're going to be seeing motor-wise is that you'll have an inability to evert and dorsiflex the foot. Okay. And this causes dropped foot. okay? Foot drop syndrome or dropped foot, okay? Foot drop. All right. And lastly, you will lose sensation of the dorsum of the foot. So the top part of the foot along kind of the upper portion, more lateral portion of the shin. Okay. But remember, the dorsum of the foot also is involved. So the key takeaway points for the common peroneal nerve or the fibular nerve is PED, PED. So this is how we remember it. PED, P stands for peroneal, E stands for everts, and D stands for dorsiflex. So you lose the ability to evert and dorsiflect your foot, and it ends in dropped foot. And luckily, dropped ends in PED. So that's how you remember all of this. Okay? Second thing you have to remember is that the loss of sensation is on the dorsum of the foot. And lastly, if you get low enough to the superficial peroneal nerve damage, you will have sensory loss between your big digit and your second digit of your toes. Okay? So that's the key thing. Next is tibial. Tibial nerve, all right, what you need to know is that the tibial will lose inversion and plantar flexion. So you will not be able to invert or plantar flex your feet, okay? And so instead of dropped foot, you'll have inability to go on your tiptoes. You can't do tiptoed walk, okay? And then the last thing is that you lose sensation of the plantar foot, all right? So tibial is plantar foot. For sensation, common fibular or common peroneal is going to be loss of sensation of the dorsum of the foot. So common fibular or common peroneal is loss of sensation to the top of the foot. Tibial is loss of sensation to the bottom of the foot. All right. Tibial is going to be inability to invert and plantar flex. And so we remember it by TIP, T-I-P, tibial, inverts, and plantar flex. So you can't stand on your tiptoes. Luckily, tiptoe starts with tip, T-I-P. All right. So that's how you differentiate between common peroneal and tibial. It's very straightforward and easy, and they ask a lot of questions on it. Next, you have the superior gluteal. Superior gluteal injury is usually due to the injection into like a superior medial gluteal muscle, right? So remember, when you do injections in the butt, if you do buttocks injections, what happens is that if you're not in the superior lateral quadrant, you can cause damage. So you always have to do it in the superior lateral quadrant. If you do it in the superior medial quadrant, it's going to cause superior gluteal nerve damage, right? Now, overall, what you're going to see is a Trendelenburg gait. Okay, and you know Trendelenburg gait relatively well. And you're going to see hip drop to the side that's not affected. All right? So the lesion is contralateral to the side of the hip that drops in the Trendelenburg gait. Lastly, what they want you to know about gluteus medius, because the gluteus medius is usually what's affected along with the minimus, but gluteus medius is going to attach to the greater trochanter of the femur. That's something that they want you to know as well. And you know that already from previous anatomy, like from M1 year. All right. Inferior gluteal nerve muscle is that you can't climb steps or stand from a seated position. And then lastly, the pudendal nerve injury. Pudendal nerve injury, what you're going to be seeing is usually during childbirth. The patient can have pudendal nerve injury because they're in that prolonged position. Also, cycling can cause it, or horseback riding. And what happens is that you're going to have decreased sensation to the genital area. It could lead to fecal and or urinary incontinence. All right. And you can also have like inability of sensation to any of the genital region. Last thing you should know is that usually when you're doing anesthesia during childbirth for like blocking like local anesthetics, you can use the ischial spine as a landmark for injection so you don't hit the pudendal nerve. All right? So that's it for the lower extremity nerves. I'm going to run through it one more time so that you have it fully understand it. Okay? So you fully understand it. First, iliohypogastric is suprapubic burning pain following abdominal surgery. Next, genitofemoral nerve is going to be absent cremasteric reflex. Next, lateral femoral cutaneous is going to be tight clothing, obesity, or pregnancy that leads to meralgia paresthetica, which is decrease in the sensation of anterolateral thigh. Obturator nerve is going to be decrease in adduction or adduction after pelvic surgery. Femoral nerve is going to be decrease in patellar reflex, and leg extension can be caused by retroperitoneal hematoma or psoas abscess. Sciatic nerve is going to be usually due by posterior hip dislocation, which is seen in patients that are frail and elderly who fall, or patients that have a motor vehicle collision where their knee hits the dashboard. The leg will appear shorter and internally rotated if it's a posterior hip dislocation. It can also be caused by piriformis syndrome, where the piriformis compresses the sciatic nerve. The sciatic nerve is going to split into the common peroneal and tibial nerves. The common peroneal nerve, you're going to see inability to evert and dorsiflect the foot, and you will have loss, which is known as foot drop, and you'll have loss of sensation of the dorsum or top of the foot. If there's a superficial peroneal nerve abnormality, you're going to have sensory loss in between the large toe and the second toe. For tibial nerve, what's going to happen is that you'll have the inability to invert and plantar flex, so you cannot go on your tippy toes, and you'll have a loss of sensation of the plantar foot. Superior gluteal is going to cause Trendelenburg gait. It's usually due to injection into the superior-medial gluteal rather than the superior-lateral gluteal, where you're actually able to inject and where you should inject. Remember that the gluteus medius and gluteus minimus are affected here, and the hip drop is going to be on the contralateral side of the lesion. The gluteus medius attaches to the greater trochanter of the femur. Inferior gluteal injury is going to be can't climb steps or stand from a seated position. And the pudendal nerve, you're going to see decrease in sensation to all genital area with potential fecal and or urinary incontinence. It could also be due to the fact that a patient is in the pregnancy position for too long during childbirth. It could also be caused by prolonged cycling and horseback riding and induced by local anesthetics during childbirth. So in order to avoid this problem, you can use the ischial spine as a landmark for injection. That's all that you need to know for lower extremity nerves. Please reach out if you have any questions.